Good afternoon. My name is Jennifer Cardellini, and I'm the Director for Consumer Information at Benjamin Rose Institute on Aging. Thank you for joining us for the 15th Annual Katz Policy Lecture, sponsored by AARP Ohio. Today's webinar will be recorded. During the webinar, you may submit a question at any time using the control panel on the right-hand side of your screen. We have staff monitoring the chat to convey your questions to our presenters and to answer any technical questions you may have. If you would like to tweet with us during today's lecture, please use our Twitter handle at BenRose1908 and our event hashtag #KatzLecture. I want to thank our sponsors for making today's lecture possible, including our presenting sponsor, AARP Ohio, and our program sponsor, HW&Co. Now I'd like to turn it over to our President and CEO, Orion Bell, who will introduce today's lecture and our first speaker. Orion?
Hi. Thank you, Jenny. Good afternoon. My name is Orion Bell, and I am the President and CEO of the Benjamin Rose Institute on Aging. Thank you for joining us today for the 15th Annual Katz Policy Lecture. This year, the National Family Caregiving Strategies and Policy Recommendations from the Raise Family Caregiving Advisory Council, sponsored by AARP Ohio. The Katz Policy Lecture was established in 2007 in honor of the late Dr. Sidney Katz, Benjamin Rose's distinguished scholar. The lecture convenes advocates to explore potential policy approaches to important issues of aging. Dr. Katz was a physician, a scientist, a teacher, a mentor, an author, and a public servant who pioneered the concepts of active aging and championed development of the field of geriatric care. And he was the primary author of the concept of activities of daily living that are so widely used today. The Katz family has remained strong advocates and supporters of our work throughout the years. And today we also want to acknowledge and remember Beverly Katz, the wife of Sidney Katz, who passed away earlier this year. Sid and Beverly were true partners in their lives together and great champions of his work in the field of aging. This year's lecture will examine the Raise Family Caregivers Act, which directs the U.S. Department of Health and Human Services to develop and maintain a national strategy to recognize and support family caregivers. The act identifies actions that communities, providers, the government, and others are taking to help family and friend caregivers and aims to improve information sharing, collaboration, government support, and assessment of caregiving programs. Our keynote speaker, Dr. Alan Stevens, will discuss family caregiving strategies and policy recommendations from the Raise Family Caregiving Advisory Council and the impact that these recommendations will have in our communities. Following our keynote speaker, a reactor panel of industry experts will give their responses to the presentation and discuss how the Act impacts different types of individuals and communities. To begin today, I want to thank our presenting sponsor, AARP Ohio, whose support makes today's lecture possible. Joining us to offer remarks on behalf of AARP is Rhonda Richards. Ms. Richards is a senior legislative representative in government affairs at AARP nationally. In this role, she advocates for older adults and their families in Congress and with the administration, focusing on issues including support for family caregivers, helping people live independently in their homes and communities, home health, residential care, and post-acute care. She has successfully advocated for provisions in federal law and regulation, including the Raise Family Caregiving Act, and has received the AARP Lynn Bodiford Award for Excellence in Advocacy. Prior to her involvement with AARP, Rhonda served on staff of the U.S. Senate Health, Education, Labor, and Pensions Committee, where she played an important role in the advancing and enacting of bipartisan legislation, including the reauthorization of the Older Americans Act, and the establishment of the National Family Caregiver Support Program. She has also worked in the office of former U.S. Senator Barbara Mikulski and is a graduate of Bryn Mawr College. Please join me in welcoming Rhonda Richards.
Well, thank you very much. Thank you for the opportunity to join you today for the 15th Annual Katz Policy Lecture on National Family Caregiving Strategies and Policy Recommendations from the Raise Family Caregiving Advisory Council. AARP Ohio is pleased to be the presenting sponsor of this important event. It is time near one of the milestones in the implementation of the Raise Family Caregivers Act, the release of the Raise Family Caregiving Advisory Council's initial report to Congress. First, I want to acknowledge and thank the Benjamin Rose Institute for the work that they do in the Cleveland area and well beyond to support caregivers and empower all people to age well through research, consumer responsive services, and client advocacy. They are making a difference every day in the lives of older adults and family caregivers. I'm honored to be delivering opening remarks today at an event that pays tribute to Dr. Sidney Katz, an amazing pioneer and leader in aging. Family caregiving touches just about everyone. Most of us are, have been, or will be a family caregiver or someone who needs the assistance of one. Family caregivers are all ages, races, and ethnicities, and cut across all segments of our population. They have common, but also unique and diverse needs. Supporting family caregivers, defined broadly, is a priority for AARP nationwide, including through advocacy, information, connections to peers and resources, research, and more. AARP was engaged in and a strong supporter of the Raise Family Caregivers Act from its very beginning. We worked with the bill's sponsors, Senators Susan Collins and Tammy Baldwin, and former Representative Greg Harper and current Representative Kathy Castor around the bill's first introduction in July 2015. Raise requires the development, maintenance, and updating of a strategy to recognize and support family caregivers by the Secretary of Health and Human Services, or HHS. The legislation brings together representatives of the public and private sectors and different stakeholders, such as family caregivers, older adults with long-term services and support needs, persons with disabilities, veterans, providers, employers, and others on the Raise Family Caregiving Act Advisory Council to advise and make recommendations regarding the strategy. The strategy will identify recommended actions that communities, providers, government, and others are taking or may take to recognize and support family caregivers in a manner that reflects their diverse needs. Raise was actually modeled on the National Alzheimer's Project Act that similarly called for a national plan for Alzheimer's disease and related dementias. AARP led a group of national organizations supporting the legislation and advocating for its passage. Ultimately, over 80 national organizations supported the bill and worked on various tactics to help advance it in Congress. The final version of the bill passed the House and Senate and was signed into law by the President in January 2018. The Administration for Community Living, part of HHS, took the lead on implementation of the Act and chairs the Advisory Council. The members of the Advisory Council were appointed in 2019. AARP's former National Volunteer President, Dr. Catherine Alicia Georges, serves on the Advisory Council, which first met in August 2019. One of the Council's first key deliverables under the law is their initial report to Congress, which also helps inform the development of the national strategy. An important part of the report is 26 recommendations approved by the Advisory Council that will serve as the framework for the national strategy. AARP thanks the Advisory Council for their work producing this important report and recommendations, including those to give family caregivers some financial relief and more support in the workplace. As the Council points out, America's family caregivers are the backbone of our care system, and they are breaking under the strain. It is time for policymakers to take action. AARP is calling on Congress to enact a family caregiver tax credit this year, as well as legislation to provide paid leave for caregiving and expand access to home and community-based services. At the state level, AARP Ohio has leveraged resources to successfully champion legislation that helps family caregivers, including the passage of surprise billing legislation that protects consumers against surprise bills from out-of-network providers. Reliable access to quality health care is a top priority for AARP members in Ohio. Our healthcare campaigns focus particularly on removing restrictive and outdated barriers that prevent people from accessing the full range of care provided by advanced practice registered nurses, reducing the high cost of prescription drugs, and expanding the use of telehealth technologies to make it easier for family caregivers to care for their loved ones. Going forward, the Advisory Council's report, recommendations, and the national strategy could bring additional support to some efforts underway to assist caregivers, and that they can also serve as a roadmap and catalyst for future efforts to recognize, assist, include, support, and engage our nation's family caregivers. It will be critical for both the public and private sectors to take action to meet the diverse needs of caregivers. Family caregivers must see meaningful and tangible outcomes. I also want to acknowledge and thank the fantastic staff at ACL, the John A. Hartford Foundation, National Academy of State Health Policy, and others who provide important support for the Advisory Council. Thank you for the opportunity to join you today. We're in for a great afternoon with excellent speakers. Thank you.
And thank you, Rhonda. It is now my great honor to introduce this year's Katz Policy Lecturer, Dr. Alan Stevens. Dr. Stevens holds the Vernon Holman Louis M. Rampey Centennial Chair in Gerontology at Baylor Scott and White Health, and serves as the Director for the Center of Applied Health Research, a system-level center that facilitates investigator-initiated multidisciplinary efforts to impact population health management with healthcare delivery and implementation science research. He is also a professor of medicine and public health at the Texas A&M Health Science Center. Dr. Stevens has dedicated his research career to investigating the clinical and organizational issues related to care delivery of older adults and their caregivers. With more than 25 years' experience in academic medical schools and a leading integrated healthcare organization, Dr. Stevens is nationally recognized for his contributions to the field of dementia caregiving, care transitions, and the management of chronic diseases. In 2012, Dr. Stevens was appointed by then-Governor Rick Perry to serve as the founding member of the Board of Directors of the Texas Institute of Health Care Quality and Efficiency. In 2014, he was invited to serve a 2-year term with the National Academies of Sciences, Engineering, and Medicine Study Committee that produced the 2016 publication, Families Caring for an Aging America. Also in 2016, Dr. Stevens joined the Texas Health Improvement Network as an advisory committee member, and currently he serves as the co-chair of the Family Caregiving Advisory Council established by the RAISE Family Caregiving Act of 2017. The committee's role is to provide recommendations to the Secretary of Health and Human Services on effective model for both family caregiving and support for family caregivers, as well as improving coordination across the various federal government programs. Please join me in welcoming Dr. Stevens.
Thank you, Lauren, and such an honor to be invited to speak at this event of honoring Dr. Katz. Truly a person who made a remarkable contribution to the field of aging and gerontology. So it's an honor to be able to be here today and be associated with such a wonderful person. And Rhonda, thank you for a great introduction to the RAISE Act and the background of the RAISE Act, and to some insight into how the RAISE was created and some of the long-term hopes and aspirations that we on the Family Caregiving Advisory Council have, as well as of those that are shared by many federal agencies that are contributing to this. First of all, as a disclaimer here, let me say that I'm presenting to you today as one of 3 of the co-chairs of the RAISE Act Family Caregiving Advisory Council. My comments do not reflect the official opinions of the council or of the administration community. Excuse me. So, again, Rhonda touched upon much of this in her introduction, which again was so skillfully done and so informative. And let me especially call out the role that AARP played in making this happen. Rhonda noted that there were many organizations involved in getting this legislation written and passed, but no other should be credited more than AARP for the work that they have done on this, and particularly my friend Lynn Feinberg, who did an amazing amount of work in this as well as part of her career at AARP. The essential goal of this act was to really bring forward the culmination, or for it to be the culmination of 20 years of advocacy and legislation that had been done on the behalf of family caregivers. So while there had been much done in the last 20 years, much research had been done, the evidence was growing and growing and growing that family caregivers faced unusually challenging struggles in their role of providing care to a family member because of that family member's health or physical condition. And that we had gotten to the point where I think it was easy to make the justification we needed, and how are we going to get to that federal strategy, and a strategy that would mean coordination among the many, many players, stakeholders, contributors to family caregiving. And we want to talk about that as we go on today. But this is family caregiving is certainly not a single dimension activity or a single aspect of our society's problem or challenge. Rather, it is a societal issue from which we have to bring together many stakeholders to address the complexity of family caregiving. Family caregiving is not a disease. Family caregiving doesn't mean crisis. Family caregiving doesn't mean that there will be negative consequences. But many times there are negative consequences. And many times we believe that those consequences, those negative consequences, can be mitigated with programs that have been shown to be supportive of family caregivers. So much of what we'll be talking about, I hope, in this presentation and in the reactor panel is the path forward. Not why do we have to do something, not what are we going to do, but what is the path forward for the numerous different activities that we need to coordinate in a forward-moving way to address the complexity of family caregiving. The Act itself has three major elements. The first is the foundation or creation of the Family Caregiving Advisory Council that I sit on, and it's a distinct pleasure to be a part of and serve as co-chair. As Rhonda said, the whole act was basically assigned for implementation to ACL, and ACL took on the responsibility for standing up the advisory council and continue to support it in very positive, robust ways today. A charge coming out of the, a charge from the Act was that the Family Council, the Advisory Council, then make a report to Congress, and then after that initial report, the annual report, and that this report to Congress serve as the foundation of a national strategy. Next slide. So when we first came together as the advisory council with both the federal and non-federal members back in 2019, there's great discussion of what is a family caregiver, and not just in an academic way, but in a truly important way of defining the family caregiver for it to be meaningful to the many, many stakeholders that were listed in this bill. Because sometimes we will get into our own areas of expertise and think, oh, a family caregiver, and limit ourselves to thinking of those of dementia patients. But this bill and the work that we're doing is much broader than individuals caring for older adults. Rather, it's individuals caring for a broad range of who need assistance due to the person's chronic condition or healthcare condition or disability or functional limitation. So this bill deals not only with children taking care of parents, but parents taking care of aging children who have had a long-term disability or a functional limitation. It's important that we understand the definition here of that a family member is also not just a blood relative, but also someone who perhaps links to the person in a very significant way in which there is a significant relationship. So important that we think of this as broad spectrum. We're thinking about individuals who require care for multiple reasons, a variety of reasons. And we're also using the term family caregiver in a sense of a very inclusive family. Next slide. The advisory council is made up of both non-federal and federal members. So the non-federal members or the voting members, and there are 15 of us who were appointed back in 2019, and then a number of different federal agencies, both within HHS and outside of HHS, have provided representatives to the council. Those are non-voting members, but they contribute enormously to the work that we do, the discussions that we have. In fact, it's a critical contribution of us bringing together those of us who are outside of federal agencies and often don't understand the nuances in which federal agencies do their work, and those that do understand that, so we can bring together the passion of the individuals who are serving on the committee, who are visionaries, and the passion of those who are working within the agencies who are equally visionary in their job of producing programs that fit within federal agencies. So I go through them today, but I do invite you to go online and at this link, and which I think they're posting in the chat box for you to be able to see the list of both the federal and non-federal members. It's important to know that most of the non-federal members have either a professional link to caregiving or a personal link to caregiving, or in most cases, both. Both or know of the field from caregiving, from policy work, research, advocacy, and then also know the role of a caregiver from their lived experience. Next slide. So the initial report, kind of the main charge that the council has been working on for the last about 2.5 years, has been now delivered to Congress, and that is our initial report. There's a link to this report we'll show here, and that's also on the slide that they'll be putting into the chat. On that link, you will find many different resources and different products that were created largely by ACL and by the dissemination unit that is run out of Nashville, which we'll talk about in a minute, that are very valuable in terms of giving context and social meaning to the report that was delivered to Congress. As a whole, the report identifies the challenges and speaks to the challenges that are faced by family caregivers. The report documents what we know about the challenges of family caregiving, challenges or how aspects of family caregiving can be seen to align directly to having negative financial consequences and health consequences to those who care, as well as identifying existing approaches that we know to be beneficial to supporting caregivers. It also includes an overview of a listing of all of the federal agencies who are currently providing programs to family caregivers, and there are many. And Meg will hopefully be joining us later. no more agency more robust and more productive in this area than the VA. So while our report acknowledges this long list of agencies and the many programs that are provided, our report also tries to add into that discussion a denominator, and that is the size of the need, the importance of the need for family caregiving services. So no doubt have made progress, and no doubt there are agencies who are doing good work. There is significant evidence, it appears, that those programs are insufficient to meet the needs of current caregivers, and certainly are insufficient to meet the needs of caregivers in, as we call, an aging America. And most importantly, of course, the report ends with the recommendations that were decided upon by the council in 2020, which we'll be going through today. Next slide. It's important, I think, it was clear from the very first meeting that the council felt that it was critical that the voices of caregivers be heard, and that those voices be voices to reflect the diversity of caregivers across the United States, both the diversity in culture, race, ethnicity, also in the culture of rural versus urban, all of the unique things that make us as a country very robust in terms of family care. The drive for family care to be part of our culture cuts across so many different aspects of our society, yet it is unique in many in all of these, in all parts of us. So there's great effort given to make sure that the report and the documentation supporting the report reflected that diversity. So working with our partners, and I'll describe them at the end, there's too many to name as we go, but at the end we'll go through them. We had a request for information from responses from caregivers that was conducted. We got over 1,600 comments. We conducted focus groups. We conducted stakeholder listening groups. And with the help of a specific agency, we were able to do 25 caregiver narratives and videos that are woven throughout the report to Congress. And these are go pretty deep into the family's experience of caregiving. Next slide. So after really months of assembling and reviewing a variety of documents that were already in the literature and in the public domain. So there we're talking about research reports, consensus reports like the was mentioned earlier, the National Academy of Medicine's report, Families Caring for an Aging America, as well as other national reports by AARP and other leading agencies across the country, as well as a number of state reports in which states on their own had created caregiving strategies or putting together caregiving strategies for their state. Sometimes those were limited towards dementia caregiving, other times more broadly. But there was a lot of information that we began with as a council. And with the support of ACL and NASHP, there was a great deal of work done by staff at these agencies to compile that information, crosswalk that information, and have a very good, and they presented this to the council, and for the council to be able to study and have a very comprehensive picture of what's out there already and what do we know. Our job wasn't to create new information or to ask for new studies to be done. Our job was to take and move forward what we knew from the field and what we knew from caregivers and move that forward in a set of recommendations. So after that deep dive into what was known was conducted, we then started looking more at the larger environmental of what do we really need to add to what we have in front of us? And how do we make sure the caregiver voices that are so critical to the recommendations we need to develop, how do we obtain that information? And also looking at the information we had in front of us, where are the gaps and where are the opportunities to look for additional evidence or additional input to say, can we make sure, or how do we make sure that what's being written in these other reports or that what has been written in research reports actually crosswalks to what caregivers are telling us. Thus, we developed this comprehensive analysis of the caregiving landscape that brought in caregiver voices, and I mentioned these already, deep stories that tell the stories of family caregivers. We had the analysis of kind of what we were hearing that was kind of growing in importance, but maybe less studied than some of the other evidence we had, such as youth caregiving. So we knew we needed to do a little bit more of a deep dive into some of those efforts. We kept our eye on the international developments around how other countries were developing strategies or had developed strategies. We brought that into the mix. And then we also had to look at very specific issues that were required by the law itself. And some of that was related to Medicare and Medicaid. So we had some policy papers written to help better understand the interface of caregiving and the impact of caregiving on Medicare and Medicaid programs and potential new developments that could take place in some very specific aspects of those two massive programs. So hear me say that they're narrow in scope of how we can look at caregiving in the lens of Medicare and Medicaid, but there were some very specific papers that were developed in relationship to that. All of that led forward to the 26 recommendations that were approved in late 2020 and make up the core of the report. Next slide. So, in the effort of moving this forward, we first developed and had been developing as we were working on all of this material and reviewing and collating and synthesizing. We came up with 5 priority areas. These would be areas in which we have very specific goals. To be written as very specific goals for improvement towards the caregiving and supporting caregivers. And then that allowed us to work within these priority areas to be more specific in the recommendations that were then presented to Congress. So, if you will, we wanted to go from this a bit more overview of here's a major priority area. There's a goal we have for making an impact on this priority. And here are the initial set of recommendations that we believe, if enacted, could start to achieve a goal related to this priority here. Next slide. So I want to go through each of these now. These is really the core of the report to Congress, or surrounds these recommendations. So, if you will, the larger report provides background information, documentation of why these are indeed our priority areas, and they are supported with the family caregiving stories, 25 of which are integrated and woven throughout the report. So the first priority area is awareness and outreach for family caregivers. The goal here is that family caregivers' physical, emotional, and physical well-being will improve as a result of expanded awareness, outreach, and education. So, if you will, this is an initial kind of public health approach of, we know we need to bring awareness, and we need to make caregiving and the role of caregivers better known across multiple sectors of our society. And like all of these areas that we're going to go through, I'm not going to go through each recommendation. They're here. You'll get the slides later. They're also on the ACL website. But in the sake of time, I'm just going to point out a couple of the specific recommendations with each of the goal areas. Perhaps we can talk more about the others in the reactor panel. But on goal 1 around awareness, I want to point out recommendation 1.2 of increased family caregiver self-identification. This is a big area that's required, had a lot of discussion, and will continue to have a lot of discussion, is the label of family caregiver. Some people embrace it because it's natural to them. They connect to the word caregiver. Many do not. There's some cultures in which the term family caregiver doesn't make sense because it's not seen as a role that is different from that of the family role of being brother, sister, mother, child. It is care is instead included in those descriptions, and caregiver is not a word that resonates. So we need to work on that larger issue, and there's no single answer to this, but we need to be aware of the differences in the ways that people identify themselves. And from that perspective, help people who are in care situations understand the value of identifying the roles that they do, what supports that they might need, and the duties that they do in the home. So it gets to that point of, is it important to label it or not? I don't know. But it sure is important for healthcare providers and service providers to know the roles that families take on in the home. And it's important for them to know that they often need extra help in performing those roles in the home. So awareness is critical to, I think, the secondary aspect, which is individuals feeling empowered to tell their story so that others understand what they're doing, the importance of what they're doing in the care home, and the supports that they need. So lots of discussion that will continue to need to be had here, but definitely a need for awareness, identification, and then engagement and activation of those who are in the care role. Another aspect here is recommendation 1.5 that I wanted to point out is the emphasis on a public-private partnership. Caregiving is part of our society. For many people, caregiving is very personal. For some people, caregiving requires support from federal and state agencies. So it's not a one-size-fits-all, but it is important that we acknowledge that ultimately caregiving is a significant area in which families need support, and it's likely that that will have to come from a combination of both public and private domains and services. Perhaps that's a thread that we can identify running through the different recommendations, and can talk about that as we go through all of the recommendations. Next slide. Here's an area, a goal, and a set of recommendations for some very important to me since I work in a healthcare environment. In that family caregivers need to be recognized more. They need to be engaged more. In fact, I would go so far as to say they need to be respected more in healthcare settings. Many of us have working in the field of research with caregivers. I've heard caregivers say, and not just once, but in many ways, or many different times, that when it comes to healthcare providers, caregivers are expected to play a huge role in the care of the individual that they're caring for, but are often ignored when they're actually in the healthcare arena. So, but it's simply, caregivers tell us, if I go to the doctor's appointment, the doctor might ignore me the whole time I'm there. But once I'm home, I'm given a list of activities, of things, of tasks that I'm expected to do for the person I'm caring for. Not an uncommon feeling, at least among family caregivers. So with that in mind, these recommendations, I'm going to point out the first two, 1.1 and 1.2. 1.1 focuses on, I think, a critical issue is, yes, we have to make changes. We need to make changes in healthcare related to how care is provided to individuals who have chronic conditions or chronic disabilities. And yes, caregivers must be included in that. But we also need to study it carefully. And the impact of policy changes on caregivers must be studied before dramatic or drastic changes are done. So this can cover a lot of different areas, but I think the main idea here is we need to make some advancements around everything from payment models to what's included in Medicare Advantage plans to home and community-based waivers. But that can't be done in a vacuum, or can't be done at least in a policy vacuum. We have to include caregivers in those discussions and research what would be the impact of caregivers on changes that are probably essential, that we may have some changes, especially in payment models. But we have to do that that is inclusive of all stakeholders, and stakeholders being one of the most important. The second is around the caregiver being an essential member of the care team. How they are respected in that way, how they're documented in that way, everything from electronic health records to communications, formal and informal communications with healthcare providers. Much work needs to be done in that area so that it's not just a cultural initiative of a hospital to say we include caregivers, but rather we also have to change the infrastructure so that caregivers can be appropriately identified in electronic health records and their role be well articulated in decision making and care decisions. The last recommendation on the slide is 2.5, which speaks to the critical issue of workforce. And I hope that you will see that workforce is also going to be a thread here that runs across many of these recommendations and certainly in the report, is that we have to find ways to have a trained workforce or develop a workforce that is sensitive to the inclusion of family members in the delivery of care. That is a pretty distinct movement from a healthcare system that has historically focused on a single person with all of the privacy rules and such written around the protection of that single person receiving care, that we need to conceptualize that a bit different around caregiving so that caregivers are more involved in the care of their loved ones. Next slide. Really busy. Apologize. I didn't want to change any of the recommendations or leave any of them out. Again, we'll point you to places where you can find them in much more readable forms. Social services and supports, of course, a big, big topic, important to everybody on the council and important to all of our stakeholders, resonating strongly in the voices of caregivers. So thus heavy in recommendations. But I think all of them are important in telling the story. And I'm just going to, for the sake of time, hit on some very few points here because it really comes down to the wording that was so incredibly important to caregivers and members of the council. In 3.1, the wording I'll focus on is meaningful and culturally relevant information. We heard that again and again from individuals who told their stories to the council is, don't assume something will be good for me. I will know when it's meaningful. Work with me to find something that's meaningful to me. The same in recommendations 2.3. Again, I'll kind of, which is actually a recommendation around respite, but the most important words that were discussed in the council are healthy and meaningful break. So respite is not the same for everyone, or what ends up giving somebody a healthy and meaningful break is not always the same service. And so we have to look at respite as not a one-size-fits-all, but somewhat go in reverse and reverse engineer this for caregivers or for the individual caregiver. What does having a healthy, meaningful break mean to them? And better define respite services with that in mind. Recommendation 3.4 is really a recommendation about social determinants of health. While this report is about caregiving is a life experience that occurs within the greater context in which the person is living and is impacted by and impacts the other aspects of a person's life that can have a huge impact on their health. So social determinants of health like food insecurity and transportation really need to be viewed too when we're talking about the experience of a caregiver. Because if the caregiver is experiencing food insecurity, providing them stress management techniques may not be enough. In fact, it may not be helpful at all. So we have to look at the context of the family caregiving situation more broadly. Again, the workforce issue is repeated in 3.9, this time focused especially on the community supports and the long-term care services supports. Next slide. Financial and workplace security, a topic of great discussion. Our recommendations here are briefer, but I think they touch upon the core concepts that need to be worked out. And I'll point two specifically around the adoption of employee for workplace policies and practices. Clearly, that's a nod to paid leave and the importance of having a model of paid leave that will work for both employers and for caregivers. And also then on 4.4, the critical nature of affordable long-term care services, whether they be in the home or in a facility. That how do we look at new models of financing for those kinds of services, and how do we make people aware of the need to have those services available? And a lot of this work, of course, needs to occur at the state level. The final goal is around the issue of caregiving, and that caregivers be more engaged as the truly engaged stakeholders in future research that is done. It's a call for a greater emphasis on a national infrastructure that would bring about more meaningful research. And I say more meaningful, not that research hasn't been meaningful in the past, but we know there's some holes in what we have to do, the holes in the research we have. Recommendation 5.1, again, I'll stress, is that we need better data just to understand the scope of the problem. When you start looking at the caregiving data, very little of it is done from a population standpoint. So we need better data to understand what is the scope of caregiving, how many people are caregiving, how do people transition in and out of the caregiving role. And importantly, we need to be moving towards a structure that will allow us to document population-based impacts of the work we're doing. So yes, we want to get to a point where we are doing population-based size service delivery and reaching large numbers of family caregivers with support. And if that's the case, we also need an infrastructure that would allow us to document the impact that kind of programming is having on population. So I'm going to speed up here a little bit. I'm running over time. Let me just quickly say, and the slides will be available, these recommendations will become the essence of the family caregiving strategy that's underway now. That strategy is being led again by ACL with our input, and it will be done in very similar ways. So the voice of the caregiver will be included, the diversity of caregiving will be included, but it will be very much more specific in the actual recommendation or the actual strategies in which we try to achieve these recommendations. Let me end a very quick video. This is only 1 minute, Oren, if we have time, or
sure.
Just one video, and then we'll end.
All right. Well, all right. Well, thank you. Thank you, Dr. Stevens, for serving as our Katz policy lecturer today. I can't think of a more important topic to speak to than the role of family caregivers. I know we have a number of questions. Jenny, I'm going to turn to you to share those from the audience.
Thank you, Orion, and thank you so much, Dr. Stevens. So our first question from the audience, how is stigma a barrier to engaging caregivers in discussions about their care situations and ultimately developing recommendations to improve the lives of family caregivers?
It is a problem, and you know we speak of it often in terms of similar to a stigma that has been associated with mental health, and I believe that to be true to some degree, and there are others who have studied this much more than me. There's another aspect of stigma around caregiving that is almost family expectations. So is there not necessarily a broader societal stigma, but almost a stigma within the family of who's expected to provide care? And you hear it both ways. Family saying, mother said, you better never put me in a nursing home, or mother said, you better never make me live with you. So both of those bring about a certain expectation that care will evolve in a certain way. And there's some stigma of, is the family doing the right thing related for the person who needs care? So yes, there is, and I'm sorry I don't have much more to answer on that, but it's an area in which, hopefully our first recommendations will speak, the first set of the first goal of better awareness will speak to more broadly.
Thank you. Our next question, do the results or recommendations from the Advisory Council at any point recognize that the overwhelming number of caregivers are women?
Yes, there is recognition of the impact on women, and I think that's especially noted when it comes to financial impact of greater negative consequences to females being pulled out of the workplace, and females also having a harder time getting back into the workplace after their caregiving role.
Thank you. Our next question, will there be a nationally mandated caregiver burnout prevention assessment, or will it be up to states to determine?
I don't see it in anywhere in our discussion of has anything ever been thought of as being mandated. Rather, making a case for the role of assessment. Broadly speaking, caregivers need, to be assessed upon not only how they're feeling regarding burden, but also what do they need from various providers. So I think what we would be more likely to see as some of these initial steps is greater recognition for the importance of assessment and some consensus on what needs to be assessed or what are the core components to make something a useful assessment. The only other where I could say where you might see more of a national alignment with the CDC around their survey measures.
Thank you. Next question, how are changes in individuals' caregiving journeys being incorporated into recommended solutions from the Advisory Council?
Yeah, a good point. That is that's documented in a lot of the stories from the caregivers. Again, we just saw a brief video, but there are 25 stories. It's a 4-minute video that highlights a lot of the caregivers, and it does show people kind of fit and leave the caregiving role. And families have to flex around kinds of things. Also demonstrates that some of these caregivers who provided testimonials are no longer in a caregiving role due to the passing of the person that they were caring for. So the idea of a transition and how individuals transition in and out of the caregiving role is very much documented in the stories. And I also think is reflected in the recommendations, in which we try to make sure that terms like flexible and meaningful and relevant are peppered pretty heavily into those recommendations.
Thank you. The availability of the workforce is currently having significant effects throughout society right now. Do you think any of the issues addressed in RAISE address this issue as well?
It's answer here. So remember, I'm answering totally for myself. It's in there. It's not strong enough. We need much more emphasis on the issues of workforce, and I think that's hopefully an area that you'll see developing more and more as we move forward. I do ask people to keep in mind this is the stuff this is getting. It's certainly not the end and should not be the end. You're recognizing that caregiving is not going to go away. Most of the issues that are talked about here are not solvable in the short term, are not solvable with a single program, but rather that's the importance of having a strategy in which we start to bring together numerous different ways we address these problems, and that we are making clear that this is the first report to Congress, but there'll be an annual report to Congress, and that this be a living, growing, evolving way of reporting to Congress and to creating and molding.
Thank you so much. And we are out of time, but thank you to our audience for submitting such great questions. And thank you again to Dr. Stevens. I'm going to pass it over back to you now, Orion.
Great. Thank you, Jenny. We now begin with the reactor panel portion of our program. I have the pleasure of introducing our panelists this afternoon, and serving as the moderator is a longtime friend and colleague of Benjamin Rose, Bob Blancato. Bob is the president of Matz, Blancato and Associates, and in that capacity he serves as the national coordinator of the bipartisan 3,000-member Elder Justice Coalition. He's also the executive director of the National Association of Nutrition and Aging Service Programs and the national coordinator of the Defeat Malnutrition Today Coalition. Welcome, Bob. Also, I'd like to introduce Philip McCallion, our first panelist. Dr. McCallion's research interests fill an important niche in the field of social work, bridging scholarship on aging populations with those with intellectual disabilities such as Down syndrome. He is the co-principal investigator of the Intellectual Disability Supplement to the Irish Longitudinal Study on Aging, a visiting professor at Trinity College, Dublin, a John A. Hartford Foundation Social Work Faculty Scholar and Mentor, and a member of the Steering Committee of the National Task Group on Intellectual Disabilities and Dementia. Welcome, Philip. Next is Mag Cabot, our second panelist, who's a licensed clinical social worker with more than 25 years supporting America's service members veterans, and their families. Ms. Cabot currently serves as the Senior Advisor for Families, Caregivers, and Survivors in the Office of the Secretary at the U.S. Department of Veterans Affairs. And in that role, she serves as the Principal Advisor to the Secretary and the Deputy Secretary on the development, adoption, and implementation of department-wide programs and policies related to families, caregivers, and survivors of veterans. She analyzes and evaluates programs and policy effectiveness and ensures the best outcomes for those who have served our nation in the military. And finally, our third panelist today is Laura Thornhill.
Where'd I go?
Who is the Senior Associate Director, Regulatory Affairs for the Alzheimer's Association and the Alzheimer's Impact Movement. She has served in this role since 2013, advancing policy for persons with dementia, caregivers, and health professionals through federal agencies such as the Centers for Medicare and Medicaid Services and the Food and Drug Administration. This is a wonderful panel, and it is my honor to turn the baton over to Bob Blancato to lead this portion of the program. Take it away, Bob.
Thank you very much, Orion. And it is a pleasure to participate in the 15th Katz Policy Lecture. It brings back memories for me, having had the honor of being the Katz lecturer back in 2010. I want to commend you, Orion, for your great leadership of the Benjamin Rose Institute, but also as a national leader in aging. On this 15th Katz lecture, we focus on a topic that has only grown throughout that time period: helping family caregivers, the 53 million of them in our country. In fact, this same year, we celebrate the 21st anniversary of the National Family Caregiver Support Program, a vital program in the Older Americans Act and the first specific bill passed on behalf of family caregivers. Dr. Stevens did an excellent job providing both an overview and important details about the initial report to Congress of the RAISE Family Caregiving Advisory Council. Back in 2018, when the RAISE law was signed into law, one of the highlights of its implementation was to be this report. The council was created in an expeditious fashion and did its work. A rare example of work progressing through not only two different administrations, but two different Congresses, because the issues of family caregivers should only be bipartisan. This report succeeds because the work of the council in developing it heavily involved direct input from family caregivers. That makes both great political and policy sense. There are so many critical points in this report, I'll just touch on a few. Some of the most important of the recommendations are those that strive to improve and better coordinate federal programs and activities to support family caregivers, and to have that coordination be federal, state, and local in nature. Fragmentation in this day and age is deadly in the competition for resources. Coordination, which can involve getting the most from existing resources, can be a springboard for future additional resources. I also support another key goal to engage family caregivers as partners in healthcare and long-term services and supports. Family caregivers are critical to ensuring quality care and must be in the centerpiece of conversations about health and social services. It is also vital, as this report states, that there be financial and workplace security for family caregivers. The stress associated with caregiving, which often is a sudden responsibility, should not be compounded by concerns about lost income or no relief from daily costs associated with caregiving. That is why, and the timing of this report is so important, we must include two things in the pending Build Back Better bill. One, a family caregiver tax credit, and two, 12 weeks of paid leave to all workers to care for ill family members, including those working for private employers and for governments, as well as self.
Bob, we have lost your audio.
The enduring legacy of the RAISE legislation is the National Family Caregiver Strategy, which the report notes, quote, will provide a national roadmap toward greater recognition, assistance, inclusion, support, and engagement of family caregivers, unquote. It will be about more person and family-centered care, better education and information, more robust respite options, and as mentioned earlier, better coordination of federal programs and more financial and workplace security. It is not always the norm that a law passed does actually what it's supposed to do. The RAISE Family Caregivers Act is one that has absolutely done what it is supposed to do. Let me commend the members of the Advisory Council, a number of whom are friends and colleagues, and especially Dr. Stevens. And let me also commend Lance Robertson and Allison Barkoff, who as administrator and acting administrator of ACL kept this important work on track to deliver what has been produced today. So now let's turn to our panel. Our first question, are there some themes that Dr. Stevens presented that you would like to respond to? Let me start with Philip.
Yes, and thank you for the opportunity to be here and be part of this. I was very struck by, in terms of the priority goals, that certainly all 5 are important, but that idea of engagement of family caregivers as partners, and then also the goal around services and supports for family caregivers. Certainly in my work with family caregivers of people with intellectual and developmental disabilities, families often talk to me about that it's either or. Either I'm the partner and I'm doing the work, or else people actually recognize that I have needs too. So I do think that there is something very important happening here to realize and to emphasize and support that that families play both roles, however defined. Also really pleased by the definition of family, but I think that when we think about caregivers within intellectual and developmental disabilities, we have such a long history of there being a group of staff caregivers, people that we now call direct support professionals, who have created family-like homes for individuals and who find that they are treated as family when, as they see it, it suits all of us in the policy and the services network. But then it comes to a point where we say that they are not part of what we consider family caregivers anymore. So I would hope that you would also think about that in the midst of how you're defining caregivers and how you're viewing the needs of caregivers.
Meg?
Well, thank you, everyone, and thank you so much for inviting me to be a part of the panel as well. So my background is really focused on caregivers of veterans, and certainly that population runs the whole life spectrum. We have individuals who are caring for their young spouses, so individuals who are 20, 22, who are caring for their young 20 to 22-year-old spouse, all the way up to older aging veterans who are caring for their spouse who requires some assistance, either physical injury or cognitive disability, such as Alzheimer's or a traumatic brain injury, or perhaps there was an injury early on during service. For example, I think about our Vietnam era veterans, and now there's some sort of age-related dementia on top of whatever that physical injury is. I'm struck really by 2 themes, and I think we find this a lot in our caregivers that we work with in VA. It's really about training and education. There's the training and education we need to do of those actually providing the care, the caregivers, not only about, and I tend to bucket that into a couple different places. One is the training they need to actually do the care. So it's the how to wake someone up who's having a terrible nightmare. If they have post-traumatic stress, and this is one of their particular symptoms. It's the training about how to care for a wound. It's the training of how to assist someone moving from a bed to a wheelchair, that actual training. Then there's the training of their role as caregivers, what it means to, one day be a wife and the next day be a caregiver and a wife, and how does that play itself out in your relationship? And then there's the training of, which kind of goes along with the second bucket, of all the different resources that are available. There's just so much out there, both in the veteran space, but also outside of the veteran space, because, as many of my colleagues like to remind me, veterans are people too. So they're actually often eligible for all kinds of other programs and resources outside of VA, and we have to really teach people what's available to them. And then what I think is great about some of the RAISE recommendations are that they talk about teaching and training staff as well, medical staff, clinicians, about how important the role of the caregiver is. And I, as a social worker, certainly I get this, but in many other clinical professions, it's not common to talk about the role of the family. I certainly remember in my days of doing hospital discharge planning, having a physician be shocked that when they were writing a script for IV antibiotics, that did not mean that a nurse would come 3 times a day to administer the IV antibiotics for the entire 8 weeks that he was prescribing it for, that they would maybe come twice, usually just once, to teach someone how to do it. So I think that training is key across the board.
Okay, Laura, nice to see you again.
Good to see you as well. Thank you so much to the organizers for the invitation to be with you today. And a huge thank you to the members of the Raise Family Caregiving Advisory Council. I've observed all of the public meetings, and it's no surprise that their expertise and thoughtful debate and discussion has resulted in this initial report to Congress. So the theme that jumped out at me, and it may not apply in the way I'm going to describe it to all types of caregivers, but is the inclusion, which, it's no accident that it's in the title of the law. But because we frame our constituents, persons living with Alzheimer's or another dementia, and caregivers as a dyad, meaning the impact of each person's health and well-being goes back and forth. We know very, very well the difference that inclusion, meaning the caregiver is a part of whatever team we're talking about, makes a difference in every aspect of care and every aspect of life. So I encourage the council to keep this theme front and center as they develop the national strategy.
Okay, great. So this will be a little quicker answer, but in your opinion, knowing that you did your homework and read everything that was scheduled for today, which strategies or recommendations outlined by Dr. Stevens and the Raise Family Caregivers Act report to Congress should be implemented first, and why? So Laura, I'll start with you.
Sure. So the first one that I wanted to hit, and I'm so glad Dr. Stevens highlighted this, and it gets to this inclusion thing, it was recommendation 2.2, including family caregivers as essential members and partners of the care team of the person receiving support. We, for the reasons I've described, have been advocating for this for years, and it's starting to happen for our constituents. And one example of this is there's a billing code, a care planning code for people with cognitive impairment. And among the elements that clinicians have to deliver on in order to be reimbursed, there's a specific caregiver assessment and caregivers' well-being, caregivers' capacity, caregivers' willingness. And so the fact that CMS initially wrote that element into this code as a required part, we were delighted. So I would love to see that happen for any type of family caregiver where appropriate. So yeah, I'll pause there.
Thank you very much. Philip?
Yeah, I always think about the 95-year-old mother who is still caring for her son with an intellectual and developmental disability. So she's been a caregiver for 70 years. And therefore has seen a lot of things that we have promised, and they've not always been delivered. And I think that many caregivers are much more in a show me kind of mood around some of these things. And so anything that speaks to services and supports that people can access is probably the first thing that families want to. I don't think that, for example, the awareness and outreach for family caregivers, people are going to ask, so what is this going to mean? What will I receive? And so I think that we have to be thinking about what are those services and supports that will be provided. Because again, for the population that I work with, they were used to being told there were no services for them. The services were for their son or daughter.
Great. And Meg, thank you.
Well, I feel like my my co-panelists here have stolen a bit of my thunder, but the first thing I'll say is I really agree with Laura about this notion of 2.2 and being key partners. I actually want to focus on that for a slightly different reason, though, and that's because I feel like over the many years that we've all been in this space, there's been a lot of focus about getting caregivers to self-identify. And sometimes that works and sometimes it doesn't. So I would say let's move away from trying to get caregivers to self-identify. And if we focus in on having clinicians and other key partners out in the community recognize the caregivers themselves, then we don't have to get the caregivers to self-identify. We'll be providing them with services. I also think that part of that is getting individuals who need care to identify who their caregiver is. And I think that's a piece of the training of providers that we can do. You know, when there's going to be an outpatient surgery and the aftercare is complicated, being quick to say, you know, who's going to help you with this? Or when there's a new diagnosis of cognitive impairment or anything that's going to be a chronic condition, having that provider say, who are you going to bring with you next time so we can talk about this together? I know these are not things that are going to happen overnight, and there's a lot of reasons why that's complicated. But I think if we focus in on that, the individuals in the space, physicians, nurses, social workers, rehab professionals, really identifying who the caregivers are themselves, then we don't have to wait so much on the caregivers to stand up and say, I'm a caregiver.
Thank you very much. So Philip, what are some of the biggest challenges facing family caregivers of individuals living with intellectual and developmental disabilities, and what strategies or recommendations have the possibility to produce the greatest impact to address these challenges as outlined by Dr. Stevens?
I think that, as I've said earlier, so one of the biggest challenges is the length of time that people have been caregiving for. The other thing that I was very struck by looking at, particularly among the recommendations, was the definition of future planning. The future planning was identified as ensuring that people would have the supports available to be able to continue to provide care. And again, for many of these caregivers, they were told that futures planning was about the person becoming independent and moving out of the family home. And we have kind of sneaked that in some ways, that has really changed. We've done it for really good reasons. We have wanted to move away from more institutional type settings and even away from group home settings. But families are concerned about, how will I continue to do this? How do I pass this on to the next generations? I feel that for a very long time, we have said that the caregivers, and particularly this group of caregivers, are exhausted. But we've been saying that for 20, 30 years. I think what families will be looking for is what will happen that will be different. And I think that what can happen that will be different is if there are a range of services that are available that support them, that there is recognition that the family needs to be supported, that it's not about one person, and that there will be a commitment to that support being provided for an extended period, and that what is being provided will change as the person's circumstances change.
Okay, great. Thank you for that. Laura, what are some of the biggest challenges facing family caregivers of individuals living with Alzheimer's disease and related dementias, and what strategies or recommendations have the possibility to produce the greatest impact to address these challenges, again, as outlined by Dr. Stevens?
Yeah, there are so many answers to that because there's so much overlap between this report and the National Plan to Address Alzheimer's Disease, which Rhonda referenced at the beginning. So I could go on, but I won't. In terms of the challenges, it again goes back to that interplay of the health and well-being between the person living with dementia and their caregivers. So just a few examples of the stresses that are common to us but may not be experienced by other types of caregivers. Persons in the moderate to later stages of Alzheimer's, for example, start to lose their judgment, the ability to understand and communicate effectively, personality and behavioral changes, that kind of thing, results in increased physical stress, psychological stress, leads to placement in long-term care facilities, that kind of thing. And so for us, and I came back or said this earlier, but it's all about planning, right? That inclusion of the caregiver. But in addition to the 2.2, I wanted to mention recommendation 2.3, I think will have a big impact for us, integrating care through the inclusion of the family caregivers in all care coordination in transitions, because our constituents face a lot of transitions over the course of the disease and due to multiple chronic conditions in most cases with them. And then recommendation 3.7 is so timely and so relevant in terms of supporting family caregivers during emergencies. Everybody obviously has been affected over the last 18 months, but we saw a huge impact in long-term care communities, and trying to get family caregivers, in there or involved in discharge or getting back into a long-term care facility. So I'm glad to see that in here.
Great, thank you. And Meg, what are some of the biggest challenges facing family caregivers of veterans, and what strategies or recommendations have the possibility to produce the greatest impact to address these challenges as outlined by Dr. Stevens?
So I wanted to spend a little bit of time talking about respite care, because I think that's really a key component. So VA actually has the ability, and it's part of the medical services package, to provide respite care to families. It's considered to be and this goes back to some of the things that Dr. McCallum was saying, it's a veteran benefit. It's not a caregiver benefit. It's a service that's provided to the veteran. And there are a lot of challenges with the way that respite is run, because VA doesn't necessarily have its own respite providers. So they are contracting with providers in the community. And there's just a lot of issues with that. It goes back to someone asked Dr. Stevens about how that workforce and workforce development. There's also a lot of state regulations that really hinder the direct care worker from potentially providing the kind of care that's needed in the home. So things like medication, giving medications. So if a veteran requires medication over a chunk of time and the caregiver wants to be gone during that time, then the veteran doesn't get their medication. An issue that faces many of our veterans who have children, either, and I don't even mean little kids, like school-age children. There's often state regulations about children being in the home. So I worked with a caregiver once who told me that her husband, who could not be left alone because of some cognitive issues and some mental health issues, they had arranged for respite care, and it was working out really well. But her teenage kids, who required no supervision, would come home in the afternoon, make themselves a peanut butter and jelly sandwich and go into the basement and play video games or do their homework or something, and they couldn't be in the house. They would not be interacting with this direct care worker or the veteran during this time, but they couldn't be in the same place as the direct care worker because of these state regulations. So there's a lot of coordination that needs to happen between all of these different agencies, between the payers, the direct care folks, and the training that they receive, the regulations that govern those direct care workers. All of that has to somehow be managed in order for us to get to the place of having really healthy and meaningful breaks, which I think that's the thing I hear more than anything from the families that I work with, is that excuse me, figuring out how to take a break. So I would like us to really focus in on that in a whole of government way so that we can make that work for families.
So we have a unique panel that has combined brevity with thoroughness. And because of that, Dr. Stevens, I just want to ask you if, I'm going to throw you on the spot a minute, any immediate reactions to anything you heard from the panel that you would want to just embellish or comment on?
No. First, I just want to thank everybody for your comments, and clearly you all have taken the work of the council very seriously, and I appreciate everyone doing that. Whether if you disagree, agree, tell us how to do it better, whatever that is. I'm grateful for your engagement in the process. As I said earlier, this is our first report out the gate. We need to have this be annual. It needs to grow annually. Perhaps it needs to even become thematic in some of these topics that we know probably require a deeper dive into more specifics, especially Meg, your last comment about state and federal policies often needing to be aligned so that a service which would be a service that's so universally known by as respite, most universally sought after until people have a bad experience. And you go, oh my, I thought this was going to be so much different. Or, oh my, I really thought this was going to this is helping me, the caregiver, but it's not lining up with the care plan for the person requiring care. So therefore, it's no longer there. So it's something, all of the things, and Philip, you mentioned that too, about the need to look at the dyad and both how their health and well-being is often so interconnected in reality, certainly interconnected on a day-to-day basis, yet disconnected when it comes to a number of policies around their healthcare. And Laura, you mentioned the engagement in healthcare and the importance of caregivers being engaged. That it's a favorite topic of mine. Meg was part of a panel that met on this last Friday that was organized out of Cornell Medical, and great. Meg, I don't know about you, but at the end of Friday, I was also just a little downtrodden of, oh my gosh, there's so many issues we have to overcome to make this better. But we got, and what's the plan of how do we start to chip off some of these issues that has to be done in some very strategic ways. And let me say to that, that's why I am so grateful we have the federal partners that sit on the council. They're so helpful in the language they provide in terms of the balance of often a non-federal member wanting to be bold, and all of us want to be bold, but having the input from the federal members to say, yes, be bold, but it's much better language than I'm going to use, but don't be stupid. Again, they would never say that, but they kindly direct us into, but if you say it this way, if we can phrase it this way, we can get better traction. So again, while sometimes these overall things like engagement in healthcare seem daunting, I think we are getting the right people around the table to see things from every aspect of CMS being engaged to look at billing codes, and not just not creating new billing codes, but trying to figure out why healthcare systems aren't using those billing codes because they're not set up to think in terms of how do I have two people in an exam room at the same time? And I was never trained to do that. And I was never trained how to code to do this. And won't I get in trouble? So we need CMS at the table. Certainly that we need to learn from the VA and what the VA has been able to advance in a much way the institution in the country. And folks who look at HIPAA laws and interpretation of HIPAA laws that oversee meaningful use, and how are we really going to use electronic health records to advance the cause of better health and population health, but do it in a way that doesn't eliminate those who need proxy consent, or need proxy to help them use systems like patient portal. So, but all of that's represented in some way on the council because of the contributions of the federal agencies, and I think that's a real beacon of hope of where the work of the council will make a difference, hopefully in a shorter time frame, because we'll get it because of the advice that they give us.
Thank you very much, Dr. Stevens. So before I transition to Jennifer for the questions that will come to you from the audience, let me thank Philip, Laura, and Meg for their important insights of today. And without further ado, Jennifer, take it over.
Thank you, Bob, and thank you to our panel for all of your great expertise. Orion, was there anything you wanted to address to the panel before I go ahead and ask our audience questions?
Well, I think there's a question I'd like to put to the group, because I think one of the things I really appreciated about the recommendations is that it includes some things that go beyond just federal policy. There's things there that are beyond just things that happen in Washington, and realizing that so much of the rules and the regulations and the guidance is things that are state and local issues. So I guess my question for the panel and for Dr. Stevens is, how do the RAISE recommendations, how do they inform advocacy at that state and local level? What should we in Ohio and other places around the country, what should we be looking at for guidance from the recommendations from the RAISE advisory group?
Good question, and I'm going to fumble a bit. And I think, let me just say, I'm glad you see that there, because I got to tell you, it largely comes from us being aware of state strategies that have come out of a number of states, and that we tried to make sure we were inclusive of some of that work that was already coming back to the states, and in a way of beginning the coordination with what would be federal activities. One of the issues I think is critical is the public-private partnerships, in terms of understanding that, especially around these issues around the workplace and financial security for caregivers. Yes, we need some of be federally mandated, and hopefully some of that will be coming in the Build Back Better legislation. But ultimately, I think we're going to need a lot more buy-in from the employers and the employers of the states, employers within the state that are really connected more to what's the needs of the community and how do they interface with communities. I like to think of it as, one day, can we get to the point of how employers now really put large efforts into college education programs here in Texas, particularly into junior colleges, of making sure their employees get tuition payments to go to advance themselves in their career. Can we get to a point where employers really look at caregivers in the same way of, they need support, I want to keep them in my workplace, yet I know I have to increase flexibility, or I know I need to have some kind of of supplemental program for them that may not be a direct payment in their check in some way helps them achieve their family goal and remain in the workplace. So I think it's incredibly important we don't give up on that. The case, it's not the same. It's, you know, we still need the federal policy. So I'm not backing up. We need paid leave without question. But we do need more level of what to demonstrate the value of caregivers.
Thank you.
And let me just say again here, my own opinion. I think groups like AARP and the Alzheimer's Association also do a great job of crosswalking all of this federal these federal approaches out to the states, and they have their own state networks that I think look for the coordination. They look for synergies to help make things run good at the state, or make them, bad term, but have them be more fruitful when they hit the state level because of their advocacy locally. Laura, if you want to respond to that, maybe put you on the spot, but
thank you for acknowledging that, because you're absolutely right. I'm a member of our federal affairs team, but we work very, very closely with our state affairs team to make sure that, you know, we're supporting each other's work. This area is no exception, caregiving. And I'll just add that I have to believe that NASHB's involvement with this advisory council has certainly influenced what's going to happen at the state level, and will continue to influence it.
If I could jump in on that as well, like I do think that at the state and the local level, this is a great example of what's mine to do. As you look at those 5 priority goal areas, there are clearly things that can be done at the state and the local level. It's going to require both that we look at ways to reorient the resources and the staffing that we have, but it's also about being open to new ideas that are likely to come down as a result of these recommendations. This is the way we've driven a lot of changes in the aging network over the last 10 to 15 years. It's been initiatives coming out of these kinds of recommendations, and there's a great opportunity, but it'll only happen if we're already at the state and the local level to jump on board.
Thank you very much. So we did get some great audience questions, and I'd love to transition to those now for our panelists. The first audience question says, the RRF Foundation for Aging is launching a caregiver policy training to engage coalitions around the U.S. to advocate effectively on caregiver policy at the state and federal levels. What specific policies at the federal level do the panel members feel are most feasible?
I'll jump in and say, first of all, that the RF Foundation is a great foundation that has made really big difference in people's lives across the country with their initiatives. So I certainly applaud them for identifying this work. I know it comes out of their most recent strategic plan. To me, it's always about do we do advocacy in order to ensure that we implement things that are coming from the federal level, or do we, having got these broader priority areas and recommendations, do we as advocates start asking how do we really, or rather insisting, how we then shape how these things are then implemented so that they're done in a meaningful way in our communities? I believe very strongly in sort of a strong grassroots approach, as well as a macro level advocacy position. So I think that, let's have those advocacy groups begin to define what's really going to make a difference in their communities in how we achieve these priority areas.
Thank you. Our next question, family and friend caregivers are often in formal relationships. How do the Advisory Council's recommendations address these complex and diverse networks of families and friends?
Well, I think our language, we have at least tried for our language to be that, to be inclusive of those different relationships, and to be mindful of that we're not defining family as blood relatives or blood marriage relatives. Beyond that, I think the stories that we include and the stories that were so generously shared, the caregivers demonstrate that diversity. And I also think the fact that we include the mandate is to include individuals who are caregiving for not only older individuals, but for individuals with chronic illnesses or disabilities or functional limitations, means that there's a full range of relationships. And I may have said this earlier, from my aging background and aging, usually you're speaking or adult children caring for parents or aunts and uncles or cousins down the street, or that's the kind of norm of the caregivers. But having discussions with individuals who are parents caring for children with disabilities really has, I think, enlightened my view of how family caregiving changes over time for these individuals in much, much more meaningful ways than I have been familiar with from an aging perspective. And that remaining, we often talk about in aging, it's so difficult for the child to become the parent. But how it is also difficult for the parent to remain the caregiver, instead of the parent remaining a parent, but being the caregiving role. That failure to have that transition is just as significant as having to transition from a child to a parent relationship. So, again, I'm just kind of talking in generality because I don't know what the answer is. I just know that we are sensitive to that, and I think we need to look for input from folks like you all as well as caregivers to make sure that we get that language right.
Yeah, if I could just add to that a little bit, I do think, unfortunately, there is some statute for some of the services that we're able to provide in VA that defines the family caregiver in a way that's a bit too restrictive, in my personal opinion. I think we definitely, but that statute was written, a lot further back than this particular report. So I would sort of combine these two questions with the role of advocates, and as advocates, make sure that when services are defined in either state, local, or national policy, statute, regulations, whatever it may be, that we're as flexible as we can be in those definitions. I mean, I certainly, I've worked with former foster mothers who are the caregiver, with an ex-spouse who has taken on some of the aspects of caregiving to support her children, who, the children with whom she shared children with this former spouse. So I think that, families are complex, and as Dr. Stevens said, over time, that can really change. The person who was the caregiver initially, who may be doing more of the case management paperwork kind of thing, as time goes on and there may be more hands-on intimate, if you will, caregiving, that person might be a very different person that then does it initially. So I would ask all of you to really support us as we move towards policy change to make sure that we're getting those definitions right, because that is really a challenge when it comes to eligibility for some of these programs. We don't want to limit that because of the legal or the legal relationship that someone has to that care recipient.
Great. And let me do and also add that we now also need to understand that you could be a family caregiver and be paid or unpaid. It used to be kind of this dichotomy of there were paid caregivers and unpaid caregivers were family. Not anymore. And so we also sensitive to that language of being a family caregiver who is paid in some way or reimbursed in some way, not reimbursed, but compensated in some way for the care that they're providing. That does not necessarily change the emotional impact or the conflict or the family conflict that can be seen with caregiving. It just now means there may be a financial source to support that care in the home.
Such an important point as we talk about consumer-directed care and those kinds of things, where more and more programs do allow there to be some monetary money given to someone who's doing some of that caregiving. I used to say early on in my career that these were people who would be doing this anyway, even though we've started to pay them. Not sure that's the best definition either, but I think it helps give a little bit of that context. That money is one of those essential supports and services that we're providing. But I want to foot stomp the point that Dr. Stevens is making, because as we get better at providing support to these families, some of them are paid. And so we can't just dismiss them as not needing some of these other services because they are receiving some funds.
Complicated quickly, but that's another issue that has to be discussed in terms of the larger workforce issue, because really we're hopefully bringing those people into the workforce, but that also means they probably need training. They may be a child or a grandchild that needs training in the financial management of money. There's so many aspects there that it's not just, as you said, Meg, you've learned it's more than, they would be doing it anyway. It's more complicated than that, where it rolls over into being a workforce issue, and it rolls into being a factor in keeping people financially secure during their caregiving role.
Yeah, and I'll just add one little additional piece there, in that in VA, in the program of comprehensive assistance, family caregivers are given a stipend. It is not taxed. And, there's some occasionally movement on the Hill to get that taxed so that those caregivers are then paying into Social Security. So that goes to that long-term planning piece. So all the long-term implications of some of these policies really need to be thought through in a way that makes sense long-term.
It's a complex issue. There are many families who want to be families. But on the other hand, the amount of time that people are committing, and I think particularly of the video that you showed, Dr. Stevens, where in all likelihood, you have a parent who is no longer able to be part of the regular workforce because of the amount of time that caregiving represents. So what does that mean for salary history across lifetime? What does that mean for Social Security in older age? What does that mean for people's ability to do so many things? And so I think that, particularly your priority area around financial and workplace security for family caregivers, it's not as simplistic as a solution. There are some very complex family situations that are playing out here. And again, as we say that we are anticipating that you will be providing care for a very extended period of time, it means then that caregiving changes the lives of the caregivers themselves. And we're dependent upon them. What's our responsibility to that group?
Thank you. And then we have time for one final question. What is one issue you would like to see addressed by researchers which could be used to directly impact policies related to caregiving?
I would love to see more research on interventions to support caregivers, because from a policy perspective, it's a whole lot easier to make the argument to policymakers if we have data.
Thank you.
I'd add that it would be really, I think we still don't do a great job of researching the things that really matter to caregivers, that we still decide what should matter for them. We need to be listening much more. And if through this we could commit to that, I think that would be a great outcome.
For me, I would just add, I agree with both of those comments, but I would add, we often look at saving financial or sort of the health outcomes of the care recipient, and we don't do as much work with the health outcomes of the caregiver. And that's complicated. Certainly in the VA space, we have a lot of health data on the veterans. We don't have the health data on the caregivers because they're not usually eligible for care through us. The same is true in the Medicare, Medicaid space sometimes. But there are, I do think that that's an area that's sort of rich for research, is looking at that whole health piece of the care recipient and the caregiver. If the care recipient is staying out of the ER, but the caregiver is going to the ER once a month because of their high blood pressure or their diabetes or whatever it is that they can't control, that's not really helping anyone. So I think if we could look at both of those folks, we'd be in a much better place.
I agree.
Thank you. And I just want to thank you all again for serving as panelists, and to Dr. Stevens for your great lecture earlier this afternoon. I want to thank Rhonda Richards from AARP as well for your presentation. We want to ask you now that you help us improve future programs by taking a moment to complete a short evaluation survey. The evaluation is voluntary and your answers will not identify you in any way. You can access the evaluation by clicking the link in the chat, and it will also be emailed to you following today's lecture. Before you leave today, I do want to invite you all to attend our free upcoming events listed on the screen. More information and registration is available on our website at www.benrose.org. Thank you all again for joining us, and we look forward to seeing you again next year. Take care, everyone.
Thank you.
Thank you.